Hello, students. Today I am going to talk to you a little bit about sexual and paraphilia disorders. So I'm going to share with you. Okay. So we're going to learn about all of the sexual disorders in the DSM-5 and the paraphilia disorders. So there are 4 stages to sexual cycles. There's the desire phase, the excitement phase, the orgasm phase, and the resolution phase. And there can be dysfunctions and disorders in all of these phases. Okay. And the DSM-4, that should be 5, it does say it. The DSM-5 has 4 categories of sexual dysfunction. So those related to sexual desire and arousal and interest disorders, orgasmic disorders, sexual pain disorders, and paraphilias. So these are all the sexual dysfunctions, and I'm going to break these down into sections in just a minute. So as we mentioned, there are 4 categories of disorders. So we're going to start with the sexual interest, desire, and arousal category first. So there is a sexual interest and arousal disorder in women, which is persistent deficits in sexual interests, fantasies, or urges, biological arousal or subjective arousal for women. There's also hypoactive sexual disorder in men, which means a deficient or absent sexual fantasies and urges for men, and male erectile disorder, which is a failure to attain or maintain an erection of a penis. So sexual arousal disorder in women is a diminished, absent, or reduced frequency of at least 3 of the following for 6 months or more. So a lack of interest in sexual activity, sexual erotic thoughts or fantasies, initiation of sexual activity and responsiveness to partners' attempts to initiate, sexual excitement or pleasure during most sexual encounters, sexual interest or arousal elicited by any internal or external erotic cues, genital or non-genital sensations during most sexual encounters. So that just means that they're experiencing a lack of desire or arousal even when they're being stimulated by a partner. So they are having either genital or non-genital sexual sensations during the encounters, but they're still not experiencing arousal. And it causes distress or interpersonal problems, and it's not due to medical illness or drugs. So what we need to consider with all of these sexual disorders is that nothing is considered a disorder if it's consensual and if it's not causing any problems in their life. So if someone identifies as asexual and they're not interested in having a sexual relationship, and they're totally happy with it and fine with it, then you would not diagnose them with sexual interest arousal disorder because it's something that they feel comfortable with. If it's something that is causing problems in their life or they are having issues with intimacy or relationships, then you would want to diagnose this. And of course, you want to rule out all those other types of disorders that could contribute, medical issues that could be contributing to this. And then we have hypoactive sexual desire disorder in men. And so that's persistently deficient or absent sexual fantasies and desires as judged by the clinician, causes marked distress or interpersonal problems again, and it's not due to a medical illness or other psychological disorders. So basically the same thing as with the woman, persistently absent sexual fantasies and desires and no interest in sex with a partner or anyone else. And it's something that's actually causing distress in the man's life. And then we have the orgasmic disorders as well. So we're moving on from the sexual desire and arousal disorders and into orgasmic disorders. And we also know that, one could influence the other. So obviously, if there's no desire, there's very likely to not be an orgasm, and vice versa. Sometimes if people are having issues with orgasms or they're not having them, then they may be less inclined to be interested in sex. So the first one we're going to talk about is female orgasmic disorder. And female orgasmic disorder is an absence of orgasm after sexual excitement. Many women achieve arousal, but not orgasm. And early ejaculation disorder. So that's ejaculation that occurs too quickly. And this is for the man. And delayed ejaculation disorder, persistent difficulty ejaculating. So female orgasmic disorder is characterized by, on most occasions of sexual activity for at least 6 months, marked delay in frequency or absence of orgasm, markedly reduced intensity of orgasmic sensation, causes marked distress or interpersonal problems, and it's not due to a medical illness or psychological disorder, except another sexual dysfunction or the effects of a drug. And delayed ejaculation is experienced by 75 to 100% of the time, 75% to 100% of the time, without the individual desiring delay. So obviously this is not delayed ejaculation because they're interested in delaying the orgasm. This is not being able to control a delayed ejaculation. So some of the criteria here is a marked delay in ejaculation, marked infrequency or absence of ejaculation, and the symptoms have lasted for at least 6 months, and it, again, causes distress. And some features that support diagnosis here are that some sexual partners may report feeling less sexually attractive because their partners cannot ejaculate very easily. And there's other things that you want to consider when making this diagnosis. You want to try to rule out other factors that could be contributing, like partner factors. So if the partner has any health or sex issues, so you do want to ask about that if someone's coming to you for a struggle with this. And relationship factors, so communication, problems in the relationship, lack of trust, all those things can also impact sexual functioning in a relationship. So you want to ask about those things. And individual vulnerability are factors related to psychiatric comorbidity, so other mental illnesses that can contribute, or trauma or other past issues that could contribute to this. And then you also want to consider cultural and religious factors, as well as medical factors that could be related. And then there's early ejaculation, which is a tendency to ejaculate during partnered sexual activity within 1 minute of sexual activity. So obviously that could cause clinically significant distress or interpersonal problems if a partner is engaging in sexual activity that is ending very soon, and it's not due to the effects of a drug or another psychological disorder or a medical condition. But again, if it's not causing distress, it's not a problem. And then we have sexual pain disorders. These are a lot more common with women than with men. And so this is a genitopelvic pain penetration disorder, persistent or recurring pain during intercourse. It is diagnosable in both men and women, but as mentioned previously, it's very rare in men. And you want to rule out a medical cause like infection, lack of vaginal lubrication, or menopausal problems. So something could be hormonal. Obviously, we are not medical doctors, and we're not trained to diagnose medical issues. So you definitely want to refer, for almost all of these, the individuals to a medical doctor. They may be seeing you as a counselor after the fact. Maybe they've already gotten a diagnosis from a doctor and they're coming to do some talk therapy or relationship therapy to address these issues with you. But you obviously don't want to take on the role of medical doctor. You would want to make sure that they're getting a diagnosis from their practitioner as well. And most women experience sexual arousal and orgasms from manual or oral stimulation that does not involve penetration. So that's something just to be aware of. And there's a 10 to 30% prevalence rate. So this is relatively high. And so it's something that, you're going to want to be aware of. So the DSM-5 criteria for genitopelvic pain penetration disorder is a persistent or recurrent difficulties for at least 6 months with at least one of the following: inability to have vaginal intercourse or penetration, marked vulvovaginal or pelvic pain during vaginal penetration or intercourse attempts, marked fear or anxiety about pain or penetration, marked tensing of the pelvic floor muscles during attempted vaginal penetration. So this is kind of like a really tough cycle. So obviously, if someone's having pain during intercourse, they are maybe starting to anticipate the pain, which then leads to anxiety, which then leads to tension, which then makes the pain possibly even worse. It causes clinically significant distress or interpersonal problems, and it's not due to another psychological disorder, a medical condition, or the effects of a drug. So some of the etiology of some sexual dysfunctions include a variety of factors like biological and psychological issues. The Masters and Johnson's 2-tier model is from 1970, so please consider that. It's a little bit old. There are some immediate causes like performance fears, adoption of a spectator role, observer versus participant. And then there are some distal or historic causes. There could be sociocultural. So the idea is that people get about sex from their families and from the community that could cause some dysfunction and some anxieties for sure, particularly if someone's engaging in sex in a way that maybe is not traditionally accepted by the community. And if they're, internalizing some oppression, that can impact their ability to enjoy themselves and to feel free to engage in the ways that they would like. There's also biological causes. So some of these, or almost all of these issues, can be ruled out. There could be some medical issues that are impacting this. Certain types of medications, SSRIs, even for other comorbid psychological issues, can impact desire or orgasm and other things. So, you want to always encourage your clients to talk to a medical doctor, because it could be some of those biological issues that are contributing. There are also sexual traumas that can contribute to anxiety and maybe an inability to engage in sexual activity in a way that feels really good to you. And then there are homosexual inclinations. So again, this is an old model. We wouldn't even really use this term anymore. A lot of people call what used to be considered homosexual relationships same-sex partnerships, same-sex relationships. But even then, I think that the way that this model sort of looks at it is that, like, maybe someone's suppressing an urge that they haven't explored in terms of their sexual orientation. And that could still be a possibility if they're in, maybe a traditional opposite partner relationship, and they do have some unexplored sexual orientation concerns. But it could also be that someone's experiencing sexual dysfunction in their same-sex partnership and they're totally fine with their sexual orientation. So we don't want to overly focus on that in our treatment, but we want to listen to everything and try to understand what's truly going on for the couple or for the person, of course, always. And so this is another kind of model that I found from Wiley and Sons book. And it just kind of shows how the distal causes of sexual dysfunction can kind of contribute to an immediate issue. So all of these different things can come into play, and then in the immediate moment, it boils down really to usually fears about performance or shame about performance, or feeling like they shouldn't be doing something that they're doing. So that could come from the religion or even a psychosexual trauma. And if there's, some sexual orientation issues that haven't been explored, maybe that could be coming out in the moment. Inadequate counseling, and I think that has to do with maybe a lack of understanding of certain sexual concerns or issues. Alcohol can contribute to issues. And, obviously physiological, we talked about the biological problems and maybe a physical medical issue that can contribute, and sociocultural factors. So whatever is happening in the culture that could be influencing someone. And most of these sexual issues that can't be explained by a medical issue, of course, have some of these sociocultural or trauma or a variety of psychological concerns that maybe need to be addressed that could be contributing. And predictors of sexual functioning. So we talked a lot about psychological factors, physical factors, social and sexual history factors. So the things that can contribute to good sexual functioning is good emotional health, attraction toward partner, positive attitude toward partner. So those are the communication issues. Having a good relationship and a positive sexual attitude. So feeling comfortable with your body, feeling good about yourself, not feeling shame, or having, holdovers from the past in terms of maybe cultural programming or religious programming. And then physical factors like good physical health, regular exercise, good nutrition, and positive sexual experiences in the past, and sexual knowledge and skills. And so things that can contribute to poor sexual functioning includes depression or anxiety disorders, focus on performance, too much routine, poor self-esteem, uncomfortable environment for sex, rigid or narrow attitudes towards sex, and negative thoughts about sex. And physical factors can include smoking, heavy drinking, cardiovascular problems, diabetes, neurological diseases, low physiological arousal, SSRI medications, and antihypertensive medications for heart problems, and other drugs. And social and sexual history factors that can contribute negatively to sexual functioning include rape or sexual abuse, relationship problems such as anger or poor communication, or long periods of abstinence, and history of hurried sex. So good sex education can really help and contribute positively. And taking care of yourself physically and emotionally, being attracted to your partner, being invested, being interested, having good communication, those are all things that you can help with as a counselor to try to promote sexual health. So treatments for sexual dysfunction include anxiety reduction, directed masturbation, procedures to change thoughts and attitudes. So I've heard a lot about systematic desensitization being helpful, bit by bit, maybe trying to help the couple become more confident and comfortable with smaller sex acts and building up to, a full sexual experience. Sensory awareness procedures, and rational emotive therapy. So sexual skills and communication training can help. So good old sex ed and communication training. Couples therapy to talk through relationship issues that could be coming up. And then there are, of course, medications and physical treatments. So squeeze technique for early ejaculation, PDE5 inhibitors for erectile dysfunction, and then some of those type 5 inhibitors, include Viagra, Cialis, Levitra, some of those drugs that can help with that. Of course, we would not be we would not be treating that with medication. We would encourage someone to go to their doctor if that's something that they were seeking. All right, let's move on. So, we've talked about sexual arousal and desire, dysfunctions. We've talked about orgasm, and we've talked about some other related sexual disorders, and now we're going to talk a little bit about the paraphilias. So paraphilia is defined as a recurrent sexual attraction to unusual objects or sexual activities for at least 6 months, and it should only be diagnosed again when it causes distress or it's done without consent. Transvestic behaviors are really marked by distress or involves non-consenting persons. So I think that this is, cross-dressing and has been considered like a fetishistic paraphilia for some time, but it can also be something that's stigmatized a great deal. But as long as it's not hurting anyone else or things are happening without consent, then there's not a problem. And if it's not hurting the person who's engaging in it. So we got a couple of categories here of paraphilias, and one is sexual attraction based on inanimate objects, and the second is sexual attractions based on children. So remember, everything we're talking about here is related to non-consensual and harmful acts that cause distress in the person's life or someone else's life. So these are some of the paraphilias. We have fetishistic disorder, transvestic disorder, pedohemophilic disorder. Try saying that 10 times fast. Voyeuristic disorder, exhibitionist disorder, frauderistic disorder, sexual sadism disorder, and sexual masochism disorder. So fetishistic disorder is being attracted to an inanimate object. Transvestic disorder is cross-dressing, but this is different from gender dysphoria or, varied gender expression. So people who are non-binary or identify as transgender do not fall in this category. This transvestic disorder is cross-dressing for sexual arousal and pleasure specifically. And again, it's usually completely harmless, and it's not something that's considered a problem unless it involves someone else or hurts someone else or hurts the person engaging in the behavior. And so pedohemophilic disorder, this is sexual attraction to children, which of course we know can be extremely harmful to other people. Of course, there is a small category, I suppose, of individuals who never share this, never act on this, but still feel this way. But what we hear about most are usually people who act on this. Voyeuristic disorder is watching unsuspecting others undress or have sex. So spying on other people like a peeping Tom. Exhibitionistic disorder is exposing one's genitals to an unwilling stranger. So we got to look at the differences between this two. So a voyeur is someone who's looking or watching, and an exhibitionist is someone who's showing other people who do not want to see these things. And then there's sexual touching of an unsuspecting person, and that's frauderistic disorder. So that would be like anyone touching someone's private parts on a public bus, or touching people without any consent at all. And then there's sexual sadism disorder, which is inflicting pain, and sexual masochism disorder, which is receiving pain. So I want to point out that BDSM, as we know, is very popular, and it's a form of sex that people engage in. And for consenting adults who are engaging safely in these behaviors, there's absolutely nothing wrong with it, and it's not a disorder. In fact, I was just at a conference in the fall, and it's very much a culture, and it's a group of people who want recognition and want to be able to engage in whatever sexual acts that they want and not feel stigmatized for it. And often people criticize the DSM because it stigmatizes people who are engaging in behaviors that are safe and not harmful to themselves or others. So all that to say, please know that your clients may come in and they could be engaging in BDSM, but that's a culture you would want to learn about, as opposed to something you would want to shut down immediately, be afraid of, and immediately label with the person with a paraphilic disorder. So yeah, we have to be careful about that. Okay, fetishistic disorder is a reliance on an inanimate object or unsexual part of the body for sexual arousal. So this could be shoes, stockings, underwear, rubber garments, hair, feet, etc. And it occurs most often in men, and the object is often necessary for sexual arousal. So the attraction to the object is irresistible and involuntary, and fetishes often co-occur with other paraphilias. So you've probably all heard of, people with a foot fetish. And again, there's absolutely nothing wrong with it unless it causes problems in that person's sex life or in another person's life. So we want to be careful not to stigmatize people for experiencing varied sexual interests and desires. Paraphilic disorder and incest is a category of, paraphilic disorders that includes children. So if we break down the word, pedos equal child, hebi equals pubescence, and philia is attraction. So sexually arousing urges, fantasies, or behaviors involving sexual contact with a prepubertal or pubescent child. The offender is at least 18 years old and 5 years older than the victim. That varies depending on states. So you want to make sure that you're really aware of your state's laws regarding age of consent, etc. So in Texas, the age of consent is 17, and the person cannot be more than 3 years older than them. Unless they're of age of 17, then they can give consent. So you want to really look, that's, for an ethics class, but definitely look at the laws regarding sexual consent to make sure that you're aware of them in Texas. And child pornography is widely used, and of course that is illegal. Victims usually known to be pedophile, neighbors, family members, friends, clergy. Most pedophiles do not involve violence other than the sexual activity. And I know this is really hard for me even to talk about right now, but obviously this is a very serious crime when people act on it. And I really don't know the rates of people who feel this way and don't act on it. But of course we need to know what our reporting laws are. And if someone came to you and said that they were having feelings like this, you would just want to be really careful, because you don't want to break confidentiality if there's no risk to another person. But if there is a risk to a person, a child, you have to make a report. So just please remember that. And then incest is a subtype of paraphilic disorder. Seriously, y'all, try to say that 10 times fast. Or don't, because it's not a very fun topic to talk about. But anyway, thanks for hanging in there with me. Okay, so most common types of incest are brother and sister, but less common but more pathological are father and daughter. Incest taboo is almost culturally universal. So this is really not accepted in any culture, and it's genetically adaptive. So this incest won't be occurring in a house where child abuse isn't occurring. So if you hear about incest, well, that is child abuse. It is abuse, and it needs to be reported. So even if it's just child on child and not adult on child incest, then it doesn't matter. You're going to make a report because they're children, and they should, this is abuse, and they shouldn't be engaging in this type of behavior. And more than likely, because this is not a natural behavior, the child that is engaging in the abusive behavior toward the brother or sister is likely being abused themselves. So we want to get help for the whole family. And the offspring of father, daughter, or brother, sister have a greater likelihood of inheriting pairs of recessive genes with possible negative biological effects. So biologically, we are even deterred naturally from reproducing with our family members because we're too genetically similar. So there are very huge consequences for procreating with too close of family members. Okay, moving along. Voyeuristic disorder. So sexually arousing fantasies, urges, or behaviors while observing others who are unclothed or engaging in sexual activity. So this almost always occurs, it's almost always a behavior that occurs by men. And the excitement comes from knowing the victim is unaware of the voyeur, and there's an element of risk that's important. So there's this excitement that comes from, knowing that the person's unaware that the person is watching. It seldom results in physical contact, and orgasm is typically achieved by masturbation, and the victims are unaware that they are being watched. This is, of course, a sex crime, and it is against the law. And then there's exhibitionistic disorders, which is an intense desire to obtain sexual gratification by exposing one's genitals to unwilling strangers. So again, voyeuristic disorder is watching others engage in sex acts. Exhibitionistic disorder is becoming aroused by engaging in the sex act in front of someone else without their permission. Victims can be children, and it seldom results in physical contact, and it usually involves a desire to shock or alarm the victim. It's often comorbid with voyeuristic and frotteuristic disorders. So, they may want to watch others engage in sex acts, and they want to touch other people without their consent as well. Frotteuristic disorder is sexually oriented touching of a non-consenting person, and the individual rubs his or her genitals against a woman or man's body or fondles body parts. That's very gendered the way that that's written, but I meant it could be any gender, touching any gender. And it often occurs in a crowded subway or another public place, so somewhere where they can kind of get away with it. And then we have sexual sadism and sexual masochism disorders. So sexual sadism disorders are an intense and recurrent desire to obtain or increase sexual gratification by inflicting pain or psychological suffering on another person. Sexual masochism disorder is an intense and recurrent desire to obtain or increase sexual gratification through receiving pain or humiliation. Asphyxiophilia is sexual arousal by oxygen deprivation and can result in death or serious brain damage. So this would be asphyxiation or choking to an extreme level where people are passing out. So it's obviously dangerous behavior. And, I mentioned earlier there was debate over inclusion of this in the DSM-5 because so many consenting adults engage in BDSM, and as long as they are doing it safely, consensually, then there's not really a problem with it. So there's questions about whether or not it should be in the DSM at all, considering the DSM has had to evolve and change in many ways to accommodate changes in lifestyle, sexual orientation, and gender identification. Even as there's even been a lot of criticism about how a lot of these disorders impact women as well. Etiology of the paraphilias include neurobiological factors, classical conditioning, and operant conditioning. A history of childhood physical or sexual abuse, alcohol and negative effects are common triggers, and cognitive distortions. So neurobiological factors include male hormones or androgens. So because so many of the people with paraphilias are men, they don't have unusual levels of testosterone. Classical conditioning, so different ways of training the brain, and operant conditioning, so poor social skills or reinforcement of an unconventionality. History of child abuse we mentioned, and then cognitive distortions, like because the child doesn't run away, she must want me to fondle her. So those are kind of some of the justifications. More justifications include she was saying no, but her body was saying yes. And that could have been by, exhibitionistic disorder, like the way she was dressed, she was asking for it. Pedophilia, she started it by being too cuddly. I was just teaching her about sex. There's a lot of misattributing blame, denying sexual intent, debasing the victim, minimizing consequences, deflecting censure, and justifying the cause. So take a look at those for sure, because I think that it's easy for people to come up with justifications, but as we all know, engaging in behaviors in which consent is not obtained is 100% wrong. And it's a problem. So what can we do to treat this? We can enhance motivation, CBT treatment, and we can use biological treatments such as medications. You can enhance motivation. So challenge all of these justifications, and try to, if there's motivation for, there's got to be internal motivation to work on this. There's cognitive behavioral therapy, aversion therapy, covert sensitization, countering distorted thinking, and social skills and empathy training. So helping people have an understanding of how what they're doing is impacting the individual. And then castration was used in the past, but of course we know that that's not a good way to treat people. That's horrible. That's just as bad as engaging in a non-consensual sex act if you're non-consensually removing a body part. And then we have SSRIs and Depo-Provera, which is a hormone treatment. Okay, so that's all I have for you today. I know that was a lot of information, but thank you for spending time with me today, and I hope that shed a little bit of light on the sexual disorders in the DSM. Thank you, and have a good day.